Thank you all for coming. So this is going to be a mini seminar or a mini webinar, depending on how we want to frame it. And basically, the topic is manual muscle testing. And several years ago, I came up with the need to redefine what manual muscle testing is. And what's really interesting is that in that process of when I was developing the material for DNA, after I'd written the first DNA manual, I took PDTR. And then all of a sudden, the concepts that I was expressing through my movement assessment work, it had a greater context because we started to look at how specifically the nervous system is responding to stimulus. And so there's a problem with manual muscle testing. And it starts with the terminology itself, which is manual muscle testing. So manual meaning that there is an examiner and a patient, and the examiner is manually applying stimulus to the patient, and the examiner is qualifying how that patient is responding to that stimulus. Muscle, meaning that it's muscles that are responding. And here's the big kicker: testing. Testing implies duality, good, bad, pass, fail, facilitated, inhibited, yes, no. This is a binary response. It's fixed in duality. Duality keeps us in this place of it's a place of being stuck. We're judging. We're putting our experience in a box, and we have to remove that from the process. So then it becomes, what is manual muscle testing? Well, instead of using the terminology manual muscle testing, I've reframed it, and it's movement assessment. This is neutral. In movement assessment, we're looking at two different things. The first that we're looking at is how the nervous system is responding to stimulus. With an appropriately responding nervous system, or a normal response that we'll get into in a bit and define that, then we can start looking at how the structure is responding to movement. And it needs to be in this order. And the reason why it needs to be in this order is because we have to develop a conversational language to have with the nervous system. And that's what we're going to be exploring today. Now, there's two different ways of having this conversational language. One is through the structure and through movement, through receptor response, through the afferent signals that the nervous system is receiving from the periphery. From those afferent signals, the nervous system designs a response often based on past experiences. So if we look at that chunk of information, now we're going to go backwards a bit, because we're going to look at classically how manual muscle testing has been used. And I keep using the word manual muscle testing because it's convenient, even if it's not accurate. And this becomes something that we want to consider as we're having a discussion amongst colleagues and professionals. That's a very different kind of discussion that we would have with our client. I may be using nocebo language if I talk about words like dysfunction. There are no dysfunctions in the nervous system. The nervous system is coping with stimulus. And so the convenience of language, is going to be a piece that, we can dissect at another time. But first, let's look at what this, I call it a spectrum. And classically, manual muscle testing has been used as an evaluation of structure, of movement, how the ability to respond to stimulus of movement. The most provocative kind of assessment is what orthopedics are doing, where they're looking at joint integrity, ligaments, and the connective tissues around those joints. They're purposefully giving a highly provocative stimulus to see if the structure has the integrity to respond. There's a faulty premise there, though, and that is an assumption that the nervous system is able to respond. And so they're going to be getting false positives and false negatives in those evaluations. We're going to be going through that in a minute, what I mean by that. The next layer down, or level down in this spectrum, starting at this provocative scale, is the way that physical therapists will use manual muscle testing. They're using it as a graded response to movement. There's a few PTs in the room here. And so you all know that there's a graded response from 0 to 5, where 0 is the structure is unable to respond or generate force production, to 5, where the structure is able to generate what would be considered an optimal amount of force production for that particular movement. And again, that's a scale. There becomes a bit of a problem with that scale. And that is the reliability and accountability of each individual examiner is going to be different. So what I might consider as a 3, another examiner might consider it as a 4. And so this is a problem in evaluating a client's process that's just based on muscle testing. And so this is why there's a spectrum of how we correlate how a patient would be responding to the rehab process. In the late 50s, a chiropractic doctor named Dr. Goodhart developed a process called applied kinesiology. Applied kinesiology started to open up this lens that we are not just structure. We are not just bones, joints, ligaments, connective tissue, muscles, fascia, skin. We're much more than that. In applied kinesiology, they break down the relationship of structure, the relationship of our physiology, and the relationship of our emotions as interdependent systems that all fit together. One system is going to be affecting the other. This becomes a bit to take apart, because then you need to be versed in these various different systems. Now, what we're going to do is we're going to simplify it a bit, because we're going to make the assumption that none of us are trained chiropractors in applied kinesiology. And that's probably correct for most of us here. Instead, what we want to do is we want to look at this relationship of nervous system response, structural response. Now, movement and structure is what we have that's tangible. I should say more tangible. It's not completely objective. There is going to be subjective elements. Our clients' experience is completely subjective. What we see when we're observing them move is subjective. It's subjective based on our past experiences and our understanding of biomechanics and our interpretation of what we see. What's objective is how the nervous system is responding. And there's some rules within the nervous system. And these rules are based on the autonomic nervous system, or the parasympathetic and the sympathetic divisions of the autonomic nervous system. So if we're going to be starting with this element of nervous system response first, we have to be mindful that we're not challenging structure before we're challenging the nervous system. We need to create a benchmark with the nervous system first. If we think about the nervous system's ability to respond to stimulus, imagine this. You're in a very dark room. Your eyes are adjusted to this darkness. Then an extremely bright light comes on. What's going to happen with your nervous system? Your nervous system is going to go into a protective mode to, in some way, brace and support from that radical change in the environment. This is what provocative muscle testing is like. There is not a transition from no load to all of a sudden having to respond load. It's like someone is throwing a softball towards you, but you didn't know that they were going to throw it. Then all of a sudden you had to respond and react to that softball. That's a shock for the nervous system. Under very few circumstances is the nervous system going to be able to respond to that without going into a sympathetic mode. So instead, what we want to do is we want to incrementally increase the load on the nervous system so that we can discern the place where the nervous system is able to respond appropriately to when it's not able to. This becomes a very important thing. And so it's kind of like a graph. If you think of a slope, we want to start at a gentle increase on this slope instead of just jumping to this high level slope of a provocative test. So this is this first aspect that we need to consider with our nervous system. My teacher, Jocelyn Olivier, she would say less is more when it comes to the nervous system. The softer that we can be with stimulating the nervous system, and the nervous system has capacity to respond, that means the nervous system is more sensitive to stimulus and has a greater range of response capacities. This becomes an important piece. I gotta look at my notes sometimes. So when we talk about these afferent and efferent signals, as therapists, what we're doing is we're providing afferent stimulus for our client, and we're looking at how their nervous system is responding to that stimulus. When we're using movement, it becomes a kinesthetic conversation. The interstitial receptors, which are the most abundant receptors in our skin, they're sensing pressure, heat, cold, stretch, compression. And in some cases, there is some limited research that these free endings of these receptors can also provide nociceptive information to the brain. The contact that we have with our client in the skin is the very first place that we're starting to have this conversation. It becomes a notice. Can you bring your awareness to this area and feel contact? There's two different feedback loops. There's feed forward and feed back. Feed forward is noticing and responding to. Did I say feed forward or feedback? That's feedback, noticing and responding to. Feed forward is the design of a motor program or a motor response that initiates in the motor cortex or in the cerebellum or in the basal ganglia or in the subcortex, which is below the basal ganglia where reflex movements are stored. So it's also called the reptilian brain or the mammalian brain, the different layers. We want to be able to engage both, but we want to also be able to discern which one we're engaging with. Here's the reason why. We first want to be able to have an understanding of how our client is organizing. This is why in many different movement modalities, the first set of instructions are based on to observe how our client is organizing themselves. Then there might be specific cues to see if they're able to cognitively change the way that they're organizing. And if they can't, that means that that particular building block of movement isn't available for them. And there's a reason why. There's a coping strategy in place. There's an advantage to this kind of feed-forward evaluation, is that it gives the person an opportunity to reveal their preferred coping strategy. How do they like to organize? What's their go-to? Is that optimal? Is that effective? Is that sustainable? Now, with feedback, the afferent signal goes into a couple of different places in the brain. We're just gonna, at this point, we're gonna talk about the thalamic tract, which is in the limbic system, or the limbic center. When information from the periphery goes into the thalamus, it gets parsed out. It gets parsed out to the hypothalamus. Is there a memory or an association that we can use from a past experience that will allow us to respond to that particular stimulus? Depending on the different ways that we have responded to that stimulus in the past, the particular coping strategies that we have learned from past experience, that is going to inform how we respond in the present moment. This becomes very important because muscle behavior and muscle response is often the symptom. It gives us a benchmark, but it's not the cause unless there's been specific trauma to the structure where there's a disruption of tissues. It's very rare that the structure is creating a movement response. It's in the brain. It's the way that the brain is processing these afferent signals. It's the way that the brain has learned to cope with these learned past experiences. Here's something really awesome about motor learning. Because we have the capacity to learn to and cope with our environment. We also have the capacity to learn a new pattern. And this is what we're doing in a therapeutic setting with either movement work or manual release, is we're giving the brain information so that another opportunity will present itself so that it can learn something different, a different way of coping. And this is like the gift. This is the gift of compensation. I like to say compensation is the hero. Compensation is not bad. Compensation is awesome. If it wasn't for compensation and our ability to create these kinds of coping strategies, we would not be able to adapt to our changing environment. We would not survive. And the same is true for the autonomic nervous system. Meaning, without our ability to have a sympathetic nervous system response, we would not be able to survive to our changing environment. We need that. It is necessary. There's a caveat here, because we have two divisions. We have the parasympathetic and the sympathetic. The parasympathetic division, this would be our rest and digest. This is where our endocrine system balances out our hormonal secretions. This is where we're able to process our vitamins and minerals, and we have to have proper digestion. This also is a place where we have access to motor skills. So, high-level martial artists, they train their parasympathetic, sympathetic threshold so that under duress, they're able to access their skill sets, to remain in that parasympathetic mode, even if they need to rev up their system and then it can come back down. And they can do it in between heartbeats. And this is what happens with master level archers and marksmen, is they're using their breath and the exhalation phase and the control pause at the bottom to downregulate their nervous system so that their nervous system and their body is the most still between heartbeats. So, how does this fit into the paradigm of movement assessment? This becomes very important. There is going to be a threshold of stimulus when our client moves from a parasympathetic state to a sympathetic state. We need to be able to identify this. Ideally, in our movement evaluation, under a no or low load environment, the nervous system should have capacity to remain in the parasympathetic zone. If it doesn't, it's feeling threatened. That threat is activating a coping strategy to keep mind, body, spirit safe. We need to be incremental so that we can identify this. when we start looking at the problem with traditional manual muscle testing, it starts with the duality of a binary system, meaning it's either responsive or it's not responsive. It's facilitated or it's inhibited. I'm getting a yes, I'm getting a no. This doesn't account for the division of the autonomic nervous system. We have to change our process so that we can account for the autonomic nervous system. If we go to, I'm not sure what page it is. I think it's 4 or 5. It's page 5. The movement response graph. Now, unfortunately, my printer was out of ink. So it was out of colored ink, so I don't have it. But if we look at this center line, the center line on this bell curve, we start to see the division. The first thing is the division on the left side of that bell curve is the parasympathetic division. And the division on the right side is the sympathetic division. Each one of these divisions has 2, I'm going to say general responses, because they're actually a spectrum of themselves. And for those of you that have done PDTR, you know that that spectrum of response is more qualified. But we don't have to do that here. We're going to look at it just through the general lens now. So at the very end, or the very beginning of this bell curve on the left, we have the inhibited response. That's saying that the nervous system is unable to respond to stimulus. More times than not, that is a symptom. It is a symptom of something. It might be a symptom of that the afferent signal isn't able to be sending through the nerve, and the motor neuron doesn't have the synapses and it's not firing. It might be that the afferent signal is not moving up into the appropriate motor control center so that a response can happen. It might be that there is something else in the system that is utilizing resources that it would need to activate. For example, if you have a patella ligament injury, the afferent signal from the patella is going to inform the cerebellum to protect that patella tendon by inhibiting the muscles that would act on the patella. There isn't a problem with the muscles. It's the ligament sending this afferent signal. Now, why the ligament is sending the afferent signal is another piece. That's another process to discern. So inhibited responses, those are benchmarks. Those are clues. And we want to recognize that those are the symptoms also. So what is the next phase on this graph, which is normal? This actually becomes the most important piece here, because we have to define a normal response before we can get into what is an abnormal response. So what's a normal response? The nervous system should have capacity to temporarily excite or temporarily inhibit. These aren't fixed. These are temporary responses. Later, we're going to look at how we can use a stimulus to these interstitial receptors to temporarily inhibit the nervous system. There's a couple of different ways that we can do this. We can use different kinds of mechanoreceptors to do this. We can use the muscle spindle. Now, if we compress the muscle spindles so that those fibers move together, that is sending a signal to the brain. That afferent signal is going up. When it reaches a threshold where the brain perceives that it can no longer sustain that level of excitement, it's going to send a signal to release. This is why the technique strain counter strain is so potent, because you're putting the nervous system, or the structure, I should say, in a closed position. You're putting compression on these muscle spindles. The brain is recognizing that and temporarily releases the muscle. That's the coping strategy. Golgi tendon organs are the opposite. Golgi tendon organs are like load cells, meaning they're sending the brain the information of how much force is being applied to that ligament or tendon as it's lengthening under load. When it reaches its threshold, when that afferent signal level goes up to a threshold where the brain says, I need to protect the body because this is not sustainable, it will inhibit the muscles that would act on that tendon or ligament. There's also Golgis in other connective tissue structures. So it's not just limited around the joint capsule. This is where people that are hypermobile and they do stretching or yoga or these kinds of movements where they're literally dumping into their joints and stretching the ligaments around the joint. The sensation that they're feeling is the muscle releasing from that afferent signal, but they don't recognize or feel the afferent signal from the ligament that's informing the cerebellum to release that muscle. This is also why there's no conclusive evidence that stretching pre-event for athletics reduces injury. it's not a good warm-up. It doesn't warm up the nervous system. It actually can create inhibition. There's a second way that we can have this conversation with the nervous system. And this is with our intention. This is with limbic resonance. Our nervous system, when we're in contact with another person's nervous system, there is communication that's going on. One of my teachers of neurology, he would say that the brain is processing 9 billion bits of information per second. We're only consciously aware of several thousand. There is so much going on that we don't have a conscious relationship to. And this is where this spectrum of limbic resonance is. It's much like if you look at our ocular system, how we have foveal vision and our peripheral vision. Our foveal vision is a finite set of inputs that are processed in our left brain. Our peripheral vision takes in all this information of sensory and feeling that we don't have necessarily a conscious relationship to. This is why when we're observing people's movement, we want to look at what we're seeing through soft eyes. We want to be looking through the white space because it gives us more information than this left brain cognitive evaluation. So we can use limbic resonance to ask the body questions. This becomes a two-sided sword, however, because if we're not clear in our intention, if we have our own predisposition, meaning the emotional context of our life, the injuries in our body, our organ meridian imbalances, these kinds of influences will affect our interaction with our client. Now, how many of us have had the experience of, I hurt my shoulder, then all of a sudden, everybody that comes to us has a shoulder injury? We may be creating that so that we can, through a surrogate, work on ourselves. And so this whole interaction that we have with nervous system to nervous system is complex. This is why we have to be our own client first. The more clear we are, the more space we can create to be clear with our clients. So in the demo, I'm going to show a very simple technique so that we can qualify that the nervous system is normally responsive. This is going to be the most important benchmark to get out of this binary conversation so that we can get into a non-binary conversation. When we get over to this right spectrum of the movement response graph, when we enter in the sympathetic division, these are the inappropriate responses. These are the first two false positives. The first one is I've dubbed as functional dysfunctional. This is a movement that appears to be functional. But within that movement, there is a coping strategy that is not optimal. It requires more resources than necessary. It's not efficient. If we keep driving that movement, the requirements of the environment up, that movement afferent signal is going to increase, and it's going to move from a functional dysfunctional movement to a hypertonic movement. The hypertonic movement is this initiation of fight, flight, or freeze. In functional dysfunctional, we're not quite there in fight, flight, or freeze, but our nervous system has gone into vigilance. It's ready for it. This is the reason why we see this flipping of responses when we're going from one muscle test to another, back to another, is because we're stimulating these sympathetic responses. We're going to break that down in a minute. The only way that we're able to vet out these sympathetic responses is by creating a benchmark. That benchmark is going to be an indicator muscle. So there's going to be two pieces that have to combine: a direct movement evaluation and an indicator. That indicator has to be qualified. It needs to be able to excite and inhibit. If it can't inhibit, that means that that movement is hypertonic. It becomes a faulty benchmark. Talking about the false negatives becomes a little bit more tricky. If we look at the movement response graph, and we're on this sympathetic division where we're at the hypertonic scale, you'll see that the bell curve drops off to that x-axis, to a zero, basically. What's happening there? Everything requires resources. In a hypertonic response, the resources are available. However, those resources may not be sustainable. When those resources cease to be available, we will see the first false negative. It will appear that the nervous system is unable to respond from that inhibited side of the scale, but actually it is happening from that sympathetic side. It's not happening from the parasympathetic. Again, it's a symptom. It's a symptom that the particular coping strategies that are related to that movement, there aren't enough resources to sustain that coping strategy. It's going to bring us back to why has the nervous system needed to utilize that coping strategy. That's how we're going to restore normal movement response. The second false negative is a little bit more tricky than the first false negative to vet out. And that's related to sequential movement. And this is related to how we're evaluating kinetic chains. I use the analogy, instead of saying muscles, is just use letters, muscle. Movement A, movement B, movement C, movement D. Movement A appears to be normally responsive. Movement B appears to be normally responsive. Movement C appears to be inhibited. Movement D appears to be inhibited. We need to discern if movement C is inhibited because it flipped to an indicator, because movement B invoked a sympathetic response. It was functional dysfunctional. It's not that movement B needs to be released. Movement B needs to be evaluated. This is also why we need to assess movement in the clear first. And then we look at how movement combines. There's an exception to this. This is feedback movement. The exception to this is setting an initial benchmark with feed-forward movement. Like, what does your overhead squat look like? What does your plank position look like? What does it look like, your ability to take a long inhalation all the way up to the scalenes and a full exhalation all the way down to the pelvic floor? Those are feed-forward movements. This idea of a global indicator becomes really important. This is why it's important. When we're using a qualified indicator, meaning that we've qualified that the nervous system is normally responsive, the global indicator is not a qualified response. It's a reflex of the nervous system to keep the container safe. I've been overwhelmed in some way, I'm just going to shut down. This is a freeze response. If we keep challenging the nervous system, When the nervous system has gone into this sympathetic mode and these freeze responses, if there isn't sustainable resources available, that person is going to go limbic. They're going to have a limbic response, and that limbic response is going to be based on the coping strategy that is being overly stimulated. This is why we have to be very careful in our assessment processes, that we don't overstimulate the nervous system. We're not going to learn anything about that person's nervous system and their ability to appropriately respond while in the sympathetic state. We want to do all of our assessment work from the parasympathetic state. And if we have stimulated their sympathetic nervous system, we have to downregulate that and ensure that our benchmark with our indicator comes back to this place of normally responsive. And if we can't do that, then we have to stop that process of assessment. That may be a different toolbox going from the sympathetic stimulus downregulating the nervous system. There's a couple of very simple tools that we can use for this. One tool from educational kinesiology is called the brain buttons, and that's the kidney point and the umbilicus. I think it's kidney 21 or 27, I don't remember. Stimulating these points is a general tonic for the nervous system, and it helps to bring the nervous system down. Cranial sacral is a, thank you, Sue, kidney 27. Thank you, Sue. Cranial sacral is another general tonic. You may be familiar with a kind of work that's called Traeger work, which is a gentle rocking and shaking of the body. It's putting a waveform in the body. That can be a general tonic as well. So there's different formats that we can use to downregulate the nervous system if we've stimulated this sympathetic response. So I think we're at a place where we need to demonstrate this, because it's fine and good to have a philosophy, and I think it's important, but without something that's concrete or demonstratable, that philosophy has no context. And so we need to put some context into this. Now, if we go to the page before last, there's a table. That table is what we're going to use. So let's take just a quick few minutes for a bio break. I need to reset up my room just temporarily so that we can do a demo.
Do you want to take 5 minutes?
Yeah, let's do a 5 minute.
So 8 after the hour, wherever you are.
Yeah, and then if you have that that practicum chart, have a pencil so that you can follow along and write the notes that I have from the evaluation process. Don't fix anything.
Okay, Shorts, I'm going to put you on mute.
Okay.
Joseph, I can see Tristan from head to toes.
Can you see my hands on the table here?
You know what? Let me hang on one second. Yes. So what we're going to do is we're going to encourage people to go into speaker view and they'll be able to see you great.
Okay.
You are not muted. Do you want me to mute you?
Sure. What do you use this rack for? Froggies and stuff. Are we about ready to start? Hey, Jamie. How are you?
They have 1 more minute, Shorts.
Oh. You warm enough? Yeah. Okay. I'm going to have you sit on the table first. I just wanted to have you in the middle, sit on the middle. There you go. Perfect, perfect, perfect. Is everybody about ready? Yeah, I see some people.
So just quickly, if you don't know how to do it, if you are on a computer in the upper right-hand corner, you should see either speaker or gallery. If you get it into speaker view, then the screen is going to be bigger on or spotlighted on Joseph and Tristan, which will make it easier for you to see what's going on. And if you're on a device like a phone or a iPad, if you swipe left or right, you should be able to get to where these guys are the main frame on your device, which is going to help when you see where Joseph is connecting with Tristan. All right.
Can everybody hear me?
You're quite clear.
I'm quite clear. Awesome, awesome. So this is my son Tristan. Hello. And a little bit of history with Tristan. He's an athlete. He's a long distance runner. He's an adventure runner. So he does hill running in the mountains. He likes to brag about vertical game. Last year, he experienced an injury in his peroneal compartment, or excuse me, his posterior tibial compartment, in which he thought it was shin splints, and he tried to run through it. It wouldn't let him. He did a run where he was training for a marathon, and he was pushing his mileage up pretty quickly, and he did a long run. He did it, what was it, like a 27-mile run? 26. 26. And after that, his body said, no. And so there was a process of restoring the mobility of his foot and ankle and leg compartment. And that was actually the last time I worked on Tristan. And so I'm honestly, I don't know what I'm going to find right now. One of the things that I do know about Tristan's lifestyle right now is that for the last 6 months, he's been training to be a firefighter. And so the rigors of that kind of training in combination with his running, he's gotten his mileage back up. You know, that puts a lot of toll on the body. And so he was just telling me, I was asking how he was doing. He was just telling me his back's a little bit sore. And so something will show up. So given that, the very first thing that we need to do is we need to create this benchmark with the nervous system. I'm going to show you a couple of different ways of having this conversation with the nervous system to see if we can have this conversation. So we're going to come to this typical anterior deltoid assessment, and I'm going to have you hold up through here. Hold, hold, hold. Good. Let that relax. I'm going to use a muscle spindle technique, and I'm going to press the muscle fibers together on the anterior deltoid. Hold through here. Temporarily inhibits. That's normally responsive. Come back here. Hold through here. Good. Relax your arm. Compressing the muscle spindles again. Normally responsive. That's good. I'm going to show you another technique using the Golgi tendon organs. I'm going to have you turn so that your knees are on this side, so that your shoulders here. Good. So we're going to go to that same anterior deltoid test. Hold through here. Okay, good. Now, we're going to bring the arm back, and I'm going to be feeling for that first barrier right there, the first barrier of the anterior deltoid. Now I'm going to support the joint capsule. I'm going to hold the arm so that I can pull the arm like a full lever. And I'm gently distracting it from the joint. And I'm going to wait for that release. And there it is. You feel that start to soften? Yeah. Hold through here. Temporarily inhibited. That's a normal response. See how quickly his nervous system restored from temporarily inhibited back to normal. Just a few seconds. This is very good. So this is all very good. Now, let's look at another way that we can do this. We can look at these interstitial receptors, and we could stimulate the skin, and we can temporarily inhibit the nervous system with this skin response. What this looks like is this. Hold through here. I'm going to pinch the skin. Normally responsive. Here's the beauty of this. I can go to any part of Tristan's body to do this skin receptor. Now, if I pick a place in the body and I do the skin stem, but it doesn't normally respond after I've already equated that, that gives me some information that there is something going on in that part of the body that might be part of the fractal that I would need to assess in the process. For example, hold through here, come to the forehead, normally responsive, come to the trapezius, normally responsive, come to the thigh, normally responsive. Great. I'm going to come to the low back, normally responsive. Great. So I'm happy with that. I'm going to go to the next thing. So I'm going to have you lay down on your back with your feet at this end. We're going to go through an assessment process. I call it whiteboarding. This is just one movement. When we start looking at the 5 primary kinetic chains and the four subsystems of the breathing apparatus. We have the multifidus, the transverse abdominis, the thoracic diaphragm, and the pelvic diaphragm as the core subsystem muscles. Each one of those muscles have multiple functions. These are the multiple functions of evaluating the multifidus, and it's going to start with the sacrospinalis. Now I'm going to use a binary process first, and we're going to evaluate this in binary, and then we're going to evaluate it in non-binary, and we're going to see what the difference is. Now, I have no idea what's going to happen because I did not do a pre-evaluation to even see if anything's going to show up. But we'll find out. When we're doing the initial sacrospinalis evaluation, where we put our hands on the back of the leg, we don't want to be on the tendon, the Achilles tendon. We want to be on the soleus Achilles tendon junction. The reason why is there is a group of people that when you just engage their Achilles tendon, it will create an inhibition response. You're not evaluating the movement of the sacrospinalis, you're evaluating the movement of being able to respond to load via that Achilles tendon. When I engage the leg, the first thing I want to do is I want to get a feel for this internal-external rotation. And it feels pretty balanced. Though one of the things that I feel is there's quite a bit of muscle tension in the external rotators, creating this not very much internal rotation. But that's okay. That's just information that might come in handy. So Tristan, I'm going to have you notice both legs here, and you're going to hold down towards the table. Good. That appeared to be normal. So we're going to give this over here a facilitated. Now we're going to go unilateral right, left. So this is, instead of my right, I'm going to use Tristan's right. So you're going to hold down through here. Inhibit it. So unilateral right was inhibited. I'll go through it again after we go through all this. Notice I'm not using an indicator and I'm not qualifying my indicator. We're going to do that afterwards. Right now what we're doing is this, the standard not binary kind of assessment. So now we'll come to the left sacrospinalis. Pull down through here. We're getting a facilitated response. Now, here's the interesting thing. I already have some very good information. Bilaterally, his response appeared to be normal. I got an affirmative that his nervous system was responding. However, when I went to a unilateral movement, I got an inhibited response. And on the other side, I got a facilitated response. I already know that this bilateral response is a false positive, even though I'm not using an indicator. I already have that information. Now, let's take this another step further and let's go to the multifidus. Now, What do we know about muscles having optimal mechanical advantage? Muscles that are shorter have more advances than muscles that are longer. Meaning the open position has less mechanical advantage than the closed position. Okay? This becomes important because we're going to use this to our advantage to isolate the multifidus. Now, if we think about the multifidus as an ipsilateral rotator, if I take Tristan's legs and I rotate both legs to the right, this right leg, the multifidus is shortening. This left leg, the multifidus is lengthening. That puts the right multifidus in mechanical advantage. So the side that we rotate to is the side that has the mechanical advantage. I'm going to have you hold both legs down through here. So that is an inhibited response. And then we'll come to the other side. I'm going to rotate both legs here. Hold both legs down. That's inhibited as well. It was almost there, but that was inhibited as well. So we have a bilateral inhibited multifidi. Now, here's the thing. We're not just evaluating the multifidus. While the movement is the multifidus. The position that we're putting the body in, there's multiple things that are happening. The external rotators have to lengthen on the other side. There's ligaments that are shortening and lengthening. If there is a problem in the muscles that you're asking to lengthen, or the ligaments that you're asking to lengthen, or there could be Golgi's receptors in the joint capsule, those could be influencing the response. That becomes something to consider in a minute, whether or not it's a structural correlation to why the nervous system was unable to respond to the action of the multifidus. So now we've got a little bit of a map here, okay? Let's go through it and let's see if for any reason any of these responses changed, okay? I'm gonna have you hold both legs down. That's the same. Hold this leg down. That's the same. Hold this leg down. So those are the same. Hold both legs down. Hold both legs down. So the responses stayed the same. Okay. Now, let's change the conversation. I'm going to go around Tristan's body and I'm going to qualify that I can use any one of his appendicular appendages as a indicator. Pull through here. That's normally responsive. I'm not going to use the legs because I already know there's a problem with the legs. I need to use a different indicator. Pull through here. I can use any arm. Now, Notice that I'm not using a traditional AK indicator like the anterior deltoid. Hold through here. Why? Tristan has to maintain arm position to do that. That requires resources. The indicator may become unqualifiable if those resources aren't available over a period of time in the assessment process. I like to pick indicators that are in the client's favor in their relationship to gravity so that Tristan can just rest, because the indicator is not about testing the strength of the muscle, but how the nervous system is responding to stimulus. Through here. Good. So I can go anywhere with this skin stem. Pull through here. Normally responsive. Great. So now we're going to come back to this bilateral. Pull both legs down. Hold down through here. The indicator became inhibited. I now know that Tristan is on this scale. It's not normally responsive. Hypertonic in this is on the parasympathetic side. When you combine a direct movement with an indicator, you're looking at the spectrum here. If this is the movement response graph, it's here, then it's going to drop off and go back to there, which is a false negative. So we're going to give this an FX, functional dysfunction.
Joseph, when you stemmed the indicator, you just did a quick movement on it?
Correct.
Not a compression?
No, I just had to check it.
Okay.
Here, it's normally responsive. Moving them on, right? Hold through here.
Okay.
Right. Now, if the indicator was giving me, it appears to be normally responsive, I have to check that the nervous system has indeed stayed normally responsive with the skin stem. Okay. Oh, we're at bilateral. So let's go back to this. I'm going to change indicators. Hold through here. Normally responsive. Hold down through here. Functional dysfunction. Okay, now, I don't know if you guys could see when I had Tristan bilaterally activate extension. There was a anterior tilt in his pelvis and his chin lifted. It was very subtle. Yeah.
Do it again as a demo, please.
Super subtle.
It was more dramatic when I did it the first time.
That's because, yeah, it was more dramatic. See, Tristan noticed it was more dramatic. This actually gives, this is an important piece right here. It's called performance gate. If we acknowledge the way that a client is organizing themselves, and that client sees that as less than optimal, they want to perform for us. They're going to do whatever they can to fix it. So this is also another reason why we don't always give our client all the information about what we're doing in our process, because they're going to modify how they're responding based on that information. Okay, so now we're at unilateral right. Hold down through here. That's functional, dysfunctional also.
Joseph, do you have to go to the right indicator for the right side, or does it really matter?
Here, but we're getting functional, dysfunctional in this binary conversation. This is a conversational piece, because it could be here or here, but we don't know. And at this point, it won't matter until we decide which element we're going to go with for the next phase of the evaluation process. We'll get to that in a minute. I need to make sure that Tristan's nervous system is normally responsive, that I'm not revving up his nervous system. Go through here. And his nervous system is normally responsive still. That's good. Okay, unilateral left. Hold down through here. Hold through here. Hypertonic. This is a very important piece right here. This is Tristan's coping strategy. He's finding his stability with this hypertonic response. His nervous system returned to normally responsive fairly quickly. This is good. I wouldn't normally do this, but I'm going to do it for your all's benefit. I trust that if I overrev Tristan's nervous system, then I'm going to be able to tone it down. Hold down through here. Hold through here. Hypertonic. It's not responding to this interstitial skin stem. This is a very important piece. So, this relationship right here, that is the false positive. Let's continue on this process. So now we're going to come to the multifidus. Before I go to the multifidus, is Tristan's nervous system normally responsive? Yes. If Tristan's nervous system wasn't normally responsive, what would I do? I would come to this kidney 27 and the umbilicus, and I would tone his nervous system down. Or I would maybe go to cranials. Or I might do a little trachea work and a little gentle rocking and shaking just to tone down his system, because I don't want to keep revving up my client's system in a sympathetic state, or else it could lead to an association blowing up. Okay?
Yeah, it's just interesting.
Go down through here. Good. Normally responsive. So we'll come to the right multifidus. Hold down through here. He's able to find some action down there. Hold through here. But his nervous system went hypertonic to do it. through here. Normally responsive. We're going to come to the left multifidus. Hold down through here. Hold through here. Hypertonic. This is important because guess what? This was the false negative. We would have never have known that if we didn't do this process. Now,
Could you show that one more time, Joseph, please? Just as a repeat. Just the false negative.
Yeah.
Please, thank you.
Nervous system is revved up. My indicator is no longer normally responsive.
Joseph, when you mean false
Yeah.
positive versus false negative, it's when the muscle's originally able to fire and then you do the indicator and it goes weak. I'm trying to understand what you mean by false positive negative because that's totally new for me.
I'm going to get there. But I get your question. I'm going to have to formulate how I'm going to present it in a different way that I've said it for you, Alexis, so that you'll be able to get it. And I want to be able to use the example of what Tristan is presenting to do so. So, is Tristan's nervous system normally responsive yet? It is. So I've toned down Tristan's nervous system. I'm coming to the left multifidus. I'm asking Tristan to hold down through the left multifidus. He can't. We're going to our indicator. Hold through here. The nervous system is not normally responsive. It is in the sympathetic state. It is in this spectrum of hypertonic. Yet the muscle response is down at this bottom line of the graph, which looks like hypotonic, right? Inhibited, hypotonic. It looks like hypotonic, but it's not because it's hypertonic. The nervous system did not have the resources to respond, and the nervous system is in this sympathetic mode to cope with the response. So what does this mean for a runner? Every stride that he's cycling through his gait, he's looking for resources to accomplish that motor goal. And he's going to accomplish it because he's a driven athlete. In order to do that, he's got to keep driving his nervous system into this hypertonic state. For an endurance athlete, this also means that he's using more resources than that is efficient. This is the difference between effective and efficient. Effective gets it done. Efficient uses the least amount of resources to produce the most amount of work. Okay, now I'm going to look at this in a couple of different ways. I'm going to want to evaluate this piece and this piece first. I want to see what's causing this. And we have three basic categories. We have structural, we have physiological, and we have limbic association. Those are the three categories of applied kinesiology. Now here's something really cool there's a shortcut. And the shortcut is this. There are global therapy localizations for limbic and for physiology. If we utilize those, then we can use the process of elimination to arrive at structure. Because if it's structural, then we have to go to the specific piece to therapy localize. Now that might be, I would do a movement test, and I would ask Tristan, where did you feel that? That would be one way of going directly to it. Because Tristan's nervous system knows exactly what he needs. And our nervous systems are trying to give us that information, but it's speaking a different language. And we're using this language of movement to have that conversation. So I'm going to come to this bilateral test. I want to first make sure his indicator's normally responsive, because I'm going to be using the indicator. Good. So we're bilateral sacrospinalis. Hold down through here. Functional, dysfunctional. Put your hand on your forehead. This is this hand on your forehead. Good. Hold through here. That is the global TL for limbic. Now I'm going to take your 5 fingers like this and put it in your belly button. I've eliminated that, so then it's structural. So I'm going to have you bring your hand down. Okay, so when I do this movement, did you feel it in any particular place in your body?
I mean, I just kind of was focused on feeling it in my navel area when I put my hand there. So I can't really say that.
Okay. I'm going to make a leap. And what I'm going to do is I'm going to use a technique, it's called mechano-rub, and I'm going to come to Tristan's lumbar. And I'm just going to mechano-rub the lumbar area. I'm going to come here, come back to the indicator, no change. Now, I also know that there is a correlation often between the sacrospinalis and the subocciput. So Tristan, I'm going to have you take your hand and put it behind your head and a little bit lower. There you go. And now we're going to hold through here. Hold through here. Normally responsive. So now I have a correlation that Tristan is using the subocciput. I don't know what specific aspects are going on yet because I'd have to evaluate that. But I know that he's using resources of the subocciput to brace and stabilize the lumbar. That's what I know. Okay, go ahead and remove your hand. Yeah. I like to do this one for clients because it's super fun. Now we're going to come to this motion right here, which was functional dysfunctional. Right side. Are we normally responsive? Hold through here. Hold. Hand on TL. Good. Hold through here. Normally responsive. I'm going to have you keep that TL. It was inhibited. Hold through here. Remove your TL. Hold through here. Put your TL back on. This is how I'm creating an experience for the client to recognize how one part of the body is compensating for another. Okay, good. So now we know that these TLs are the occiput. I'm just going to put an OC here. Okay. Go ahead and remove that TL. Pull through here. Tristan's nervous system's normally responsive. Now, I want to go to this hypertonic response because I want to show you how you go from a hypertonic response and TL. It's easy to go from a functional to dysfunctional because we're negating or we're flipping the indicator. To negate or flip the indicator from hypertonic requires an extra step. So we're going to come to this unilateral left. Hold through here. Hold through here. Hand on forehead. I'm going to skin stand at the same, just right before I go to the indicator, because it would be normal responsive. That indicator would go off if that was proper TL, and it's not. Let me say that again. Go ahead and remove that. I'll have to restim it. The process is this. Stem the dysfunction, which is this unilateral left. The indicator is hypertonic. It's not responding to skin stem. With proper TL and skin stem, that hypertonic indicator will go normal. It requires those elements combined. Hold through here. Hold here. Hypertonic, fingers to abdomen. Skin stem, no change. Back of it. Hold through here, skin stem, normal. I have confirmed that the TL to the occiput normalize the hypertonic response. Okay? So now we have, this is starting to build this map right here. Let's see what happens with the multifidus. Turn both legs. Hold down through here. Now remember, this was the false negative. I'm just going to go right to a TL. I'm going to have you TL here. Hold through here. He now has the resources to respond there with this TL. Go ahead and remove your hand. Hold through here. Go ahead and TL. Normally responsive. Okay, great. So then what we've discerned is all these functions are related to the occiput providing resources as a coping strategy. We have to take this another step further now that we've ascertained that. We have to assess what's happening in the occiput. And it would be a very similar process. Now, we're not going to get into the correctives here. That's not what I'm doing here. What I'm doing here is that I want to talk about how we're getting incomplete information with a binary process. And we have to go into this non-binary process so that we can have a more complete picture of what's happening with our clients. Because these false negatives and false positives, they're going to lead us astray. I'm going to work on you later, Tristan, and we'll work on that. Okay, buddy? Thanks. wave to everybody. Bye.
Joseph, I have a quick question. It may not be time to answer it, but originally when you were doing some testing, you saw that his neck flexors, right, were firing.
Yeah, the neck extensors. Yeah, his chin went. It was
Right. So,
So
or
I-
the extensors, I couldn't see it, so I couldn't see if it was flexor or extensor. But so why do we need to go through all this? Why can't we just go to the occiput or to see which area it is
Great
in
question.
the neck or the occiput?
Great question. We have to assess what's happening in the occiput because the coping strategy in the occiput could be related to a limbic association. And if
Okay,
it's,
so
and if it's related to a limbic association, that means it's using that muscular action as a resource to protect that association.
so you're eliminating those two things, limbic and physiology first, and then going to.
I did. However, I haven't evaluated the occiput.
Right.
Right?
But that's why you went through all those steps.
That's why
first.
I went through these steps because now I know, oh, for this particular, I'm going to call it a fractal, for this particular subsystem, there is something that is happening in the occiput where the nervous system is using the occiput as a resource. I have yet to ascertain why the nervous system is using it as that occiput as a resource. This is actually the big problem with our standard muscle testing protocols. The assumption would be, oh, release the occiput to strengthen the multifidus. However, if what's happening in the occiput is related to an aspect of our physiology, if it's related to an aspect of our limbic association, that occiput is a coping strategy. We would be removing that coping strategy to strengthen something else. That something else, what's happening in the multifidus, that could be a tertiary or down the line and not be important. But what's important would be why the occiput is a resource. Why is it a coping strategy? This becomes a very important lens to shift from. That we don't want to release something to strengthen something else. That is removing a coping strategy. Instead, we have to continue the assessment process and keep going up. That occiput might take us to the jaw. That jaw might take us to a cranial suture. We want to keep going up that assessment ladder. Because if we're finding a relationship and we go into a corrective strategy and we release a necessary coping strategy for the nervous system, one, the nervous system is either going to reuse that strategy. That's the best case scenario when the environmental load goes up and the required resources increase. And it goes to that as a need. The other thing that happens, and this is something that happens in other kinds of neurological work, is that the nervous system will recognize that that particular pathway is no longer available, and it will look for another pathway to give up its resources. And this can be really dangerous because this could mean, oh, you know, instead of using a muscle, all of a sudden I'm using an aspect of my endocrine system as a resource. Then I've created a less advantageous coping strategy. So here's the other thing that we can consider. The nervous system is infinitely brilliant and it knows what its best choices are in creating a coping strategy. If we remove a coping strategy, it has to come up with an alternate plan. That alternate plan is not going to be more optimal. It's going to be less optimal. And so we have to continue on this process of discerning why the nervous system has utilized that coping strategy. Now, in Tristan's case, I would have gone to assess the occiput. Then I would have put that in my back pocket for a minute. And I would continue looking at the core subsystem of the breathing apparatus. And I would build a bigger map. And I would build that bigger map to create a global picture of what Tristan's nervous system needs so that it doesn't have to use these less than optimal resources as coping strategies. It takes a minute. Now I have several people that have been on, that have gone through the DNA program and have been in the mentorship that have had this experience of, this is a big paradigm shift. This takes a minute, but oh my gosh, all of a sudden now I'm doing more assessment work, less interaction, and creating greater change in the nervous system because we're giving the nervous system the appropriate afferent information it needs to restore homeostasis. Yeah. Okay, this is a good question time for y'all. I know that it's been a little bit, well, we've got a couple of minutes, but I'm happy to go over a few minutes and, and take your questions.
I don't have a question, but I want to say that was an excellent demo.
Oh, thanks, Scott. You've seen a couple of them.
What's that?
You've seen a couple of them.
That was good, but also it was good on the indicator practice too.
Were you self-indicating over there to correlate with what
I was. But one thing that's interesting that I found my own self-indicator mistake is that when you found the false negative, I was thinking that it was going to be because there was multifidus left, it was inhibited during the test itself. I was thinking that his indicator was also going to be inhibited. So I thought in my mind the answer, and therefore I got it incorrect.
Ah.
So that's one thing to
So
think
you
about.
influenced your answer. Yeah, baby.
Yeah.
That's right
We're
there.
doing the testing to not have a counter-transference, even when we're in the office or across the online thing. So it was a really good experience. So thank you very much for that.
Good, good. Thank you, Claire, for that comment. Would you, do you mind coming off mute and speaking to that a little bit more?
Hi, everybody. I've been learning AK and Touch for Health, and oh my God, I've been in a whole world of frustration with my very tunnel vision teachers. And yeah. I'm like, this just is just nonsense what you're teaching. It's just not right. And they're like, no, you just need to do what we say. And I'm like, but it's fundamentally wrong. And this just makes so much more sense.
Yeah.
And I'm just like this problem child in their class. But I've only got 3 more weeks to go, thank God.
Yeah, yeah. So here's something that's interesting, is that this correlation between nervous system response of the autonomic nervous system, this is new.
Yeah.
This is not in applied kinesiology text. This is something that I've put together from my experience. And even my PDTR teachers are like cocking their head a little bit at me, but a hypertonic response doesn't necessarily mean that it's a sympathetic nervous system response. But here's something that's happening that we want to recognize, is that the way that we're qualifying a sympathetic and parasympathetic response classically is hormonal secretions, heart rate, the skin response, like sweaty, clammy, that kind of sympathetic response, breath out of breath, right? Those are overt markers that are based on when flight or fight has already been evoked and it's being responded to out of need. And so there's a more subtle aspect that we're looking at here, and that is at a perception level. When our nervous system is perceiving the need for safety. Now, with these simple movement evaluations, these shouldn't be threatening for the nervous system, but they are. Why? That's the big question. And that's what we need to evaluate with our clients. And so in the Touch for Health scenario, you don't know if you're stimulating these sympathetic responses and then utilizing neurolymphatics or neurovascular stimulation to downregulate it. You don't know if it's downregulating the sympathetic response without having this benchmark of how the nervous system is responding. Now, I have a theory that in the future of physical medicine, we'll be able to accurately look at the frequency of these hormonal secretions in real time. So we'll be able to stimulate the system and in real time know how the sympathetic system responded to that stimulus. Right now, if you go and get a panel to look at your hormonal system, your endocrine system, it's a snapshot in the past. We have to have some way of having biofeedback in real time. And using these interstitial receptors as a benchmark, at this point of understanding, it's the best that we're doing. It may not be 100% accurate, but it's the best that we can do right now with the tools that we have available.
Yeah, so in the Touch for Health AK world, they don't understand false positives, which is just like mind blowing, because they're like, oh yeah, but you know, everything's testing good, so the person's good to go. It's like the container's not safe.
Exactly. Exactly. It's not good to go. If it's not safe, the nervous system was threatened by that movement. Yeah. Well done, Claire. Well done. Anybody else? I see lots of blackened screens.
Joseph, real quick, this is Mary Beth. Will you take a picture of your whiteboard and post that someplace just so we can see how you use the chart? That was just hard to see real quick.
Okay.
That tells me a lot as well.
Yeah, I couldn't see the whiteboard either, sorry.
Joseph, if you take a picture and you text it to me, I can put it in the chat for people while you continue to chat.
Who's asking me to text it?
Your wife. If you text that to me, then I'll put it in the chat for people. It's good to know he knows my voice.
That's hilarious. Who's got the next question?
Question. This is Ingris.
Hi, Ingris.
So are you basically vetting out until you find a limbic, it being the hierarchy?
No.
No? So let's say you're in this session today with Tristan and you're doing the assessing. You don't have the information of the occipitals yet. Is today's session just an assessment and you say the follow-up will continue from occipital forward? Or how do you end your session?
Oh, there's a good, that's a great question. I'm going to build out the map and I'm going to ask the nervous system, is this safe to tone down? Is this safe to clear? And I'm going to find one key foundational coping strategy that I'm going to use a neurological technique to clear. Then I'm going to reevaluate all the pieces of the map again to make sure that everything is back online. Now, the way that I've been working recently, I don't do more than 4 corrections in a session. And if it gets to the place where it's a limbic association and I'm doing a limbic processing with a client, I won't do anything other than that. But I'll make sure that I've cued in as much of the fractal as possible to that association before I would clear it. I would ask, is this safe? And that's part of using the limbic resonance. I can directly ask the nervous system, is this safe to clear? No. Is this safe to tone down? Yes. Okay, so it's safe to tone down. So then I wouldn't take that person into any kind of process to take apart, so to speak, the association, to create a new relationship with it. Instead, I would just use some cranials, Bennett points, some gentle parasympathetic mechano rubbing on structure, just tone down the system because it's not safe for the system to unpack it.
So are you saying you would have, okay, so you're finding the occipital TL. You don't have time to go and vet out the occipitals. You then go back and you ask the system what you can do for Tristan right now to just tone down or release. Is that?
No, I wouldn't, because if I hadn't vetted out the occipitals, if I didn't have time to vet out the occipitals, I would say, to your point, next time I see you, I'm going to vet out the occipitals because I don't know what's going on there and it might not be safe. That might be a necessary coping strategy. I don't want to remove coping strategies. I want to put resources into that container and not take away.
So then if you're out of time and you're sending the client out, how do you relate to the client that it's all assessment and we're not doing any treatment?
I don't have that occur because I always get to a treatment piece.
Okay.
Someone wrote something. Oh, we'll have a follow-up email. Okay. Alan's fried. Yeah, that was a lot, huh, Alan? This is a big paradigm shift. I recognize this. This is a much of a shift as that we had when we initially learned manual muscle testing from just doing straight manual therapy, or looking at movement assessment and giving someone a corrective exercise. The evaluating how the nervous system is responding to the stimulus of movement is big, big, big. Why is this so important? Not only is it important for keeping the container safe, which is this very first hierarchy, the first tenet of DNA, but also when we start thinking about coping strategies, why we have coping strategies. What is optimal, what is less optimal? What is sustainable? We start looking at that matrix, and we're looking at someone's movement, and we're giving them corrective exercises, but their nervous system is unable to respond appropriately to that corrective exercise. What's going to happen? They're going to be reinforcing their coping strategy and not strengthening the target of that corrective exercise. If we're in a manual therapy mode and we have, let's use the patella. We have an upregulated patella ligament. That person they may or may not have knee pain. Ligaments may or may not be sending nociceptive information that's interpreted as pain. We notice that their quadricep is weak, so we give them quadricep strengthening exercises. That's going to drive that volume of the afferent signal from that ligament up. This is why people don't get better with corrective exercise, because the wrong thing is being addressed. They're addressing the symptom. Muscle response is the symptom. And it is very challenging to change that lens, because we want to look at the low-hanging fruit because it's easy. Oh, Tristan's multifidus isn't firing. Let's give him some low back exercise. Oh, now all of a sudden my neck hurts because my occiput is overworked.
Hey, Joseph.
Yes.
You got a chat here. Could you please take the camera over by the whiteboard so people need to take a screenshot, or so that's just sort of a permanent image in this video, please?
That's a great idea.
Wasn't mine.
How's that?
You just open up your laptop a little bit more so you can see the top. Beautiful. Perfect. Thank you. I'd also like to add my 2 cents with Ingris's comment. The last time I was on the table in Philly, when I was being tested, nothing was safe to clear, nothing was safe to tone down. So I essentially just got off the table. I guess I'm mentally just a shit show, or emotionally, whatever the case may be. So it's just how I was presenting at that time. And then to Alexa's sort of statement that this is going to take time. This stuff is not easy. You know, just practice qualifying your indicator first. And then you can move on to asking better questions. But if you can't qualify the indicator really well, it just takes some time. Just practice with some of your best clients. And the same way you practice your NKT, your PDTR, NMR, whatever, it just takes time. So does this as well. So just stick with it.
To that note, Scott, thank you.
Yeah.
I think the most important thing that we need to remember as therapists, it's not our responsibility to fix our clients. It's not our responsibility when they come to us that we have the answer right then and there. What's important here is that we learn a process how to keep their nervous system, the container of their nervous system, safe first. First rule, do no harm. And so we're going to take a step back. We're going to take a step back and reevaluate our process. And to do that, we have to discern, is the person in a parasympathetic state or a sympathetic state? We can't even start to do any kind of movement assessment if they're coming to us and their nervous system is in a sympathetic state. Everything that we're getting, all the information that we get from any kind of movement assessment is going to be skewed. We have to evaluate from the benchmark of the parasympathetic nervous system.
Joseph, with the occiput, are we just running through the steps that we did for the spinalis and multifidus?
Yeah, oh yeah, it'd be the same.
We're just repeating the same steps. So we're qualifying an indicator, seeing if there's what's strong or weak in the clear, and then seeing if it's of doing the second chart. So we're running through.
We don't even have to do the first chart though. It's not necessary. I did that as a demonstration.
Oh, okay. So we're running through the second chart.
Yeah. I'm showing how there is a need for us to get out of this binary conversation with the nervous system because it's giving us skewed information, and without having this non-binary conversation, we have no way of knowing when that skewed information is showing up.
So, but now if we're just doing the second chart, are we just testing it against the limbic versus physiology versus structural? And then if we find it structural, looking for what's causing that to become the coping mechanism? Is that just basically
Yeah, it's somewhat. What we're doing is we need to identify what category the coping strategy is.
okay.
And then we're going to use whatever toolbox we have to continue the funnel to get to the specific, from general to specific.
Okay.
Right?
One quick question, Joseph, if you think this again. You said to find out if they're unsympathetic, that's when we cannot get a normal response to the inhibition, right? So you did all three. You did spindle cell, you did the Golgi tendon, and then you did the skin. We don't get an inhibition in any of those three. This person is fully sympathetic.
Yeah. So then that would mean that there's other toolboxes to get people from that sympathetic down to sympathetic. If that's not within your scope, like we have a couple of people here that have done PDTR. PDTR is one of those methodologies of looking at how the nervous system is responding. If that's not within our toolbox, then we have to go with what is. It might be something as lovely as cranials. Just tone down their nervous system, because we can't continue any kind of assessment process because it's only going to drive the volume of that sympathetic response up. Yeah. Fantastic, you guys. Now, I think that there is a discussion board. I don't know if Karuna is activated or not, but please bring your questions. I know that I have several of my people that have been in the DNA mentorship program that are with us, and on other discussions, they've been super helpful in helping answer people's questions. And if they're unable to help you with it, I will certainly be able to jump in and answer your questions. And I really appreciate you all being here. It was great. It's great to share this information, and I'd love to hear about your process. I know that Karuna is going to be sending out some a questionnaire, you know, a little, you know, see how you like the process that we learned. And so, yeah. Until next time, huh?
Thanks, Joseph. Thanks, everybody.
Okay, Joseph. All right.
Hey, thank you all.
Thank you, appreciate it.
Thank